right, I'm here with Dr. Kyle Gillett, board-certified family medicine and obesity medicine doctor. He is the man. You've probably seen him on Huberman. You've seen him on a bunch of podcasts. So Kyle, what did you have for breakfast?
Today I had an egg sandwich. I know you like eggs, and I like eggs as well. Had a long travel day, actually flew to Los Angeles and came to here, and here we are, and yeah, here we are.
Right on. Perfect. Well, we're going to dive into something you've probably heard about before, which is semaglutide, or a GLP-1 agonist. Now, I'm going to let you take it away and do just an overview of what this stuff is. You've probably heard about it in the world of just obesity medicine and just weight loss drugs that are out right now, but no one better to explain than you. Regardless of what diet you're doing, I think macadamia nuts are a great addition. Add more calories from macadamia nuts and replace other fats with those. My favorite macadamia nuts, I put a link down below for a company called House of Macadamia. If you are looking for a unique way to get them in, they are the only company that I know of that has macadamia nut bars where the literal first ingredient is macadamia nuts. No fluff, no garbage, not somewhere down in the ingredient list, the literal first flip it ingredient. It's awesome, okay? And then also, when you look at their just range of products, they have sugar-free chocolate covered, they have sugar-free white chocolate covered macadamia nuts, and they have a whole array of different flavors like onion, they have salsa flavor, just a great fun way to get them in. But I stand behind what they're doing, okay? They farm, they harvest right in South Africa, which is like the heart of where you can grow macadamia nuts. They process and manufacture just like an hour away from where they actually grow. So there's serious integration and control there, and they're supporting a lot of the local farmers and really just doing positive things. So that link down below will save you 20% off if you use that code. 20% off of whatever you want to get through House of Macadamias using that link down below.
So a GLP-1 agonist, semaglutide is one of the main examples. It's glucagon-like peptide 1, so I guess technically it's a peptide, although insulin's also a peptide, yes, which happens to be my favorite peptide. But anyway, GLP-1s are a class of what's called incretins. There's several other like mechanisms of action in this class, like GIPs or like DPP-4s, and these have classically been used for medications for diabetes, and they've been around for quite some time. They were famously discovered by someone looking at peptides or proteins in the saliva of a Gila monster. Exenatide was one of the first ones, then named Byetta and Bidurion. But over the last decade or two, they've been repurposed, and now they have FDA approval, or at least some of them have FDA approval for obesity. One of the reasons why they're getting a lot of press, well, one is because I guess they're back in vogue. A lot of celebrities are using them, yeah, and they also work very well. People also take them off-label for other things, and there's a lot of risks which are underemphasized in some scenarios and overemphasized in some scenarios that I would love to discuss more. Yeah,
we'll definitely get into that. So what is a gut incretin in the first place? It's something that essentially is released as a response to food, typically, right? Is it dependent on the macronutrient, or can you just give an overview of what that is in the first place?
Yeah, there's something called the gustatory response, and when you eat something that you like, especially, then this gustatory response starts a cascade of different events, one of which is the incretin, or essentially helping your pancreas start working. It's like kickstarting your pancreas like an alternator on a car, for lack of a better analogy. But there's actually a couple different places where your body endogenously produces GLP-1. It produces it in the alpha cell of the pancreas. The beta cell is where you produce your insulin and amylin. In the alpha cell, you produce some GLP-1. You also just produce GLP-1 in the gut itself. So you do release GLP-1 even if you just taste something good on your tongue and then spit it out. However, when insulin resistance develops and when the beta cells of the pancreas do not function as well, having more GLP-1 can help you get more bang for the buck out of your insulin. And as many people know, insulin can be an anabolic hormone to put on lean body mass and also body fat. And having a balance between the two processes is important. Your question about macros specifically, carbs increase GLP-1 actually relatively quickly, but then that falls off precipitously. And then over the course of many hours, both proteins and fats have a much slower response to increase endogenous GLP-1 release, but then that is sustained over many hours. So that kind of leads to the question that I assume that we'll talk about at some point, why low-carb diets tend to work better for people doing intermittent fasting.
Yeah, okay, and that was going to be a question that we'll get to in a little bit, is it starts going down too much of a rabbit hole. The viewers will probably get freaked out right now, but talking about GLP-1 and how this can interplay on a higher carb diet versus a lower carb diet, and if there's drawbacks to actually using it with a lower carb diet versus a high carb diet when you're talking insulin and kind of manipulating the sensitivity there or how you respond with a given food. So who, first of all, is a good candidate for semaglutide or GLP-1?
Yeah, so semaglutide is, since it's kind of the main example, there are many other examples. The best candidate would be someone with type 2 diabetes. If you have type 1 diabetes, GLP-1s don't work quite as well, mostly because you're not producing your own insulin. In type 1 diabetes, usually, but not always, you have cell death of the beta cells of the pancreas, which are half of the endocrine cells in the islets of Langerhans. But anyway, you don't produce the amylin and you don't produce the insulin. So other molecules that I call amylin analogs are under development, and there's actually one already that's in use, but there's a lot of drawbacks to it that are much better for type 1 diabetics. Past type 2 diabetes, people who are at risk of beta cell death are great candidates for GLP-1s. There's a study looking at something called a legacy effect, and they gave individuals 12 or 24 months of a GLP-1, and even after they remove the GLP-1, weeks later, they still have the benefit of less beta cell death and a better pro-insulin to insulin ratio. We call that an islet cell dysfunction test, and that had a sustained benefit or a legacy even after stopping the medication. So theoretically, that could prevent things like prediabetes or diabetes. And if someone is going to develop that anyway, you want to start this medication earlier. A bad candidate would be someone with one of the strict or non-strict contraindications, like multiple endocrine neoplasia, any risk of medullary thyroid carcinoma, which is a very rare thyroid cancer, risk of pancreatitis. So there are a couple different contraindications. One of the interesting ones that has not been talked about as much lately is cholestasis. So your pancreas and your liver and your gallbladder all connect through a series of tubes that you can think of as rivers and tributaries leading to them. And basically, when your gut is not having that peristalsis and that movement as often, and also as you're just not eating as much food, this happens sometimes during bariatric surgery as well. That will get clogged up, and it can lead to things like gallstones or pancreatitis, which we've already mentioned, or just buildup of things like bile acid, uric acid, even bilirubin, and even estrogen. Those things undergo what's called intrahepatic cholestasis, where if you're thinking about the estrogen bathtub analogy, there's 3 drains. One of them is glucuronidation in the gut, and there's another drain that kind of goes back in and then puts that back into the bathtub. So that's hopefully a good 1,000-foot view of all these different systems intertwining and what could make a good candidate and a bad candidate. You weigh all of those things because someone might have a lot of these attributes, but you just weigh them and then do a process called shared decision making with your physician to decide if that benefit outweighs that detriment.
Now, would you say nowadays the vast majority of people that are interested in this are just for general weight loss purposes, not necessarily for glucose modulation or for diabetes?
Probably so.
Yeah, whether that's the right thing or not.
Yeah. However, obviously a lot of the people that are interested in it for its even cosmetic benefit should also be interested in it for the other benefits that they can derive.
Yeah, and one could argue that the other benefits that are being derived are going to ultimately help them make the better lifestyle choices and develop those lifestyle factors that are going to ultimately help them lose weight, so directly and indirectly. So weight loss is essentially an off-label usage of semaglutide in this case.
For semaglutide, there is a brand name of it. It's called Wegovy, and that is approved for obesity, to treat obesity, to cause weight loss in adults and down to a certain age. But not all GLP-1s are approved for that purpose. Occasionally they are used off-label.
Okay. So walk me through what someone that's moderate to severe obesity wants to go on this. Like, if you could explain it, the best case in their shoes, what would they be feeling? What are they feeling? Is it decreases in appetite? Is it more stable glucose, whatever that might feel like to someone that's inexperienced with what stable glucose feels like? Walk me through what they would experience.
Ideally, you would experience, in some cases, slightly less appetite or a lot less appetite. Some people feel like they can hardly eat at all and they feel very nauseous, and that's not necessarily what you want. So as my colleague James, who's co-host of my podcast as well, he says the dose makes the poison. And with GLP-1s, that is also true. So I am in the camp that not every individual, especially for individuals who are kind of marginal at needing it, they do not need to increase to the very max dose in all situations. So you want to have a slightly decreased appetite, you want to be in a caloric deficit, and you also want your gut to be functioning normally. You want to have forward peristalsis, not reverse peristalsis, which is vomiting and throwing up. That's another common side effect. And then slowly increasing the dose. There's, I don't know if you could say it's a controversy, but there is a debate whether or not certain patients should plan to be on it for a lifetime. And in some cases, it's probably true. In some diabetics, especially the more severe cases, it is certainly reasonable to plan to keep people on indefinitely. Depending on the study you look at, between 75 and 90% of people regain a significant amount of weight after stopping. The lower the dose that's required during the caloric deficit and weight loss, in general, the better chance that that individual will have as they come off. That being said, in almost all cases, as I wean people off of GLP-1s, I have some other pharmacologic agent, whether it's a medication or a supplement, and you utilize that for at least 3 to 6 months after, and then close follow-up, of course.
So what is the reasoning, or what mechanism are you aiming for when you're weaning someone off? So is there a feedback loop with an incretin? Like can you stop all endogenous production if you were on these things for long enough, hard enough? And whether that's true or not, even when you're weaning someone off, in which route are you trying to intervene? Are you just trying to go a completely different axis altogether to keep the weight off and kind of allow them to restabilize and find homeostasis at the incretin level? Or are you trying to actually help stimulate endogenous production of these again?
So there's no significant negative feedback inhibition of secretion of GLP-1 itself. Alpha cells and also the gut they're very resilient. But the effects on the hypothalamus, there's 2 centers on your hypothalamus, which is kind of the control center in the brainstem, in the brain. And you have your orexigenic center and your anorexigenic center. The anorexigenic center is kind of exactly what it feels like. You're kind of tired, you don't want to eat. And GLP-1s are active in the central nervous system. Then your orexigenic center, I called it the hangry center, or the hangry hormone. You're angry, you're awake, and you're hungry. So I guess the removal of the excess signaling from the GLP-1 molecule is going to think about it as a rebound. It's almost like a dopamine detox, where you're very dopamine sensitive, and then you get back from a camping trip, you listen to a song on the radio you don't even like that much, and it sounds like the best song you've ever heard. Except it's that way for food. So there's a couple ways that you can target this. If you're eating at night a lot, then sometimes you can just shut down the signals from orexins and use orexin inhibitors. Sometimes you can use dopaminergic agents. Sometimes you can use things that are opioid receptor antagonists. A combination of low-dose naltrexone bupropion can be useful in some cases. Sometimes you can just shut down the appetite with supplements, like raucine can be a reasonable one. But it really depends on, and of course in some patients with insulin resistance, you can use a different insulin sensitizer, because GLP-1s are also insulin sensitizers in the periphery, or maybe a little bit of everything. So it really depends on the case, which tool to choose.
Is there, that you're aware of, like dietary intervention that can help as someone is maybe coming off of this? Because I think that's probably the most common question that people are thinking is like, I go on this stuff, do I have to be on it for the rest of my life? And if I go off of it, is everything going to go right back to the way it was, cattywampus, or is it, or worse, get worse, right?
Yep.
And I spend my life thinking about, okay, foods that improve insulin sensitivity, albeit it's usually short term, and it's, you look at different things, polymonounsaturated fats that can improve this. Like when you work with your patients on this, or in what you've seen, does the diet matter as someone's coming off outside of just basic thermodynamics?
Yeah, food is medicine, and if lifestyle pillars or lifestyle factors in general have been optimized while the individual's on GLP-1, in many cases they wouldn't require medication or supplement. It's just not that often to be on completely solid ground. And by that, the analogy I usually use is, you're stuck in metabolic syndrome with insulin resistance and excess body fat. It's like you're sinking in quicksand. And even if you learn how to dig out of you learn how to dig out and you know exactly how, if you don't have a tool, you won't be able to, because you'll just keep sinking in the quicksand. A GLP-1 is like a shovel. So you're just going to dig out easier. But unless you figure out how to move to solid ground with different improvements in diet, improvements in exercise, improvements in sleep, social support and social system, unless those have changed, then if you take the shovel away, you're going to sink back in.
That's a great way to put it. So jumping over to the diet types that work best during this intervention, like with GLP-1, I'm aware that these kind of things like incretins can affect how the liver produces glucose, right? So for instance, with semaglutide, I know there's some evidence that so the liver stops or slows down production of glucose. Yes. And just to give a background here, when you're on a low carb diet, when you're in a ketogenic state, or when you are intermittent fasting or fasting for extended periods of time, a big driver of energy for you is that alanine pathway for gluconeogenesis, right? And that's also very important for muscle preservation as well. Just because you're breaking down amino acids from not just your muscle, but from other substrates. So the question that kind of popped into my head when I was doing some preliminary research, talking with you, I'm like, wait a minute, so does this mean if you're potentially slowing down gluconeogenesis, is it not a good idea to do this with a low carb or a ketogenic diet? Or is it really a moot point?
I think that's mostly a moot point. Obviously the best diet is one that someone can learn to adhere to even after they're off the GLP-1. Mm-hmm. When I write my prescription pads for nutrition, which is basically learning how to intuitively eat, because if you're in this situation, you probably don't know how to intuitively eat as much as I love intuitive eating. And intermittent fasting or number of meals per day is one of them. Macronutrient content is one of them. Some people that don't like to track calories, if they track macronutrients, then you can kind of know the calories from the macros. And eating speed is another one. My favorite ones are tracking fiber or having enough fiber in the diet, especially healthy sources of fiber, including resistant starch, I suppose, including prebiotics. I know you like to talk about those things a lot.
Yep.
I also love that individuals like yourself provide tools to make it easy to find something that an individual will really like. So if you really like something, you're more likely to do it. So if you can find something that's beneficial to your health and you also like doing it, then you're going to start making these habitual changes. And then when you can hopefully remove the GLP-1 receptor agonist, or even maybe with some of these things, you don't even need them in the first place. It's just literally dietary intervention and other lifestyle changes. Absolutely.
Yeah, I mean, that's where, regardless of diet type, no matter how much it comes under fire, I'm still a huge proponent of just time-restricted feeding, and I think Mark Sisson put it really well. He called it fractal eating, which I almost like that term better. It's like, instead of just, because it doesn't have to be this, a fast just makes it black and white for people, so it's very easy, not eating versus eating. But I mean, really, what we're looking at is, as you advance with that, it's fractal eating. It's taking breaks from your food. And I think it's a good segue to talk about, I mean, do you feel, you mentioned at the beginning of this that insulin is kind of one of your favorite incretins/hormones to talk about. Yeah. Now, do you think that a lot of the problems we face outside of course, a simple calories in, calories out, because we all know that matters, I want to get that out in the open, but the consistent spiking of insulin, just the chronically high levels of insulin that are influenced independent of a pathological condition, just by constant eating, is that causing a problem for us, in your opinion?
Yeah, if it's constant spiking, there's insulin receptors all over the body. Insulin has a very fast half-life, especially compared to a lot of other hormones. So insulin and growth hormone are both very fast, but they have a lot of downstream effects. For example, in the liver, when insulin binds the insulin receptor, it's going to significantly increase the synthesis of, decrease the synthesis of SHBG, which is sex hormone binding globulin, and that is going to lead to faster metabolism of estrogens and androgens. It's also going to increase the synthesis of IGF-1, which can be both good and bad. But all of these effects over time, given significant insulin signaling and insulin spiking, will lead up cumulatively. That's one of the reasons why I'm a fan of a CGM, is because, and eventually we will be able to track insulin and track ketones and track lactate and all sorts of things, even with a CGM, which is a continuous glucose monitor. It's you usually wear it on your arm or maybe your abdomen. And these can be incredibly useful even without any other medication, supplement, or dietary change, because they can also be a tool to intuitively eat. But that's one of the best ways to get an idea of when insulin's spiking, because you can see the spike and subsequent crash of blood glucose.
Yeah, no, I'm a huge fan of doing that all the time. And plus, especially when you cross-reference with an Aura and a Whoop and you start looking at all your data and kind of where things, because of course, you're going to have different responses to foods at different times of the day, to different stimulus and different stress levels and different sleep. And I agree, I'm a huge fan. I think being able to teach people how to read that data is very, very important, because data without understanding data is usually detrimental. Like if you just give someone a continuous glucose monitor and you say, here's your blood sugar, it might just freak them out. And I think understanding the dynamics and the insulin dynamics that go with it is very, very important. Is there an interplay, we'll kind of wrap this up, but an interplay between GLP and, you talk about estrogen and how the metabolism of estrogen, I'm assuming we're talking all types of estrogen, not just 1,7 hydroxydiol or 1,7H estradiol, but it's, so it's not just helping you metabolize bad estrogen. It could go too far as well. So how does this kind of play? Because I'm curious personally, because I'll put myself up here on the chopping block. My estrogen levels are practically non-existent because I stay lean too long, right? It's a negative thing, right? And so my estrogen levels just tank. Is it a similar kind of interplay there? And it has to do with gut incretins that could be that issue.
It can be a similar interplay. It can definitely lead to cholestasis, as we mentioned, and intrahepatic circulation of all types of estrogens. However, it is well known that, especially as females start GLP-1s, it is common to skip a menstrual cycle, or skip a menstrual period, not really skip a cycle, but to have what we call oligomenorrhea, which is no period for 35 or more days. So there's a couple different proposed mechanisms of this, but excess estrogenic signaling is certainly one of the common ones.
Interesting. Okay. So at the end of the day, if people are considering, what's sort of the hierarchy that people may want to consider if they're looking at pharmaceutical intervention, and we're going to do another topic specifically on probably the 5 most common weight loss compounds that are out there, or drugs that are out there. But is semaglutide high on the list, GLP-1 high on the list, or do you think there are other boxes that need to be checked, in your opinion?
Yeah, it depends on the individual. As the percentage of body fat increases, I like to go by definitions of obesity by body fat percentage. DEXA scan is a decent enough way. But semaglutide would be very high on the list, along with any GLP-1 if it's indicated in that patient.
And then one last question, does oral or injection make a difference in terms of the form?
It can certainly make a difference. At this time, the only approved medication for injection, the only approved GLP-1 is an injectable version, but oral works quite well as well.
Same mechanisms, everything's happening the same, it's just rate of absorption, or is that all it is?
For oral GLP-1s, you have to take it daily, fasted, kind of similar to how you take thyroid hormone. So it has a proprietary absorption where it does not significantly pass through the usual absorptive way in the liver. So it could work better or worse depending on if somebody has malabsorption or whatnot. So if somebody has chronic IBS-D or bariatric surgery or something like that, then there'd be other things to think about as well. But for some patients, injectable is certainly superior.
Okay. And then if someone like myself, a very lean person, were to take, because I'm seeing this, like I'm seeing it more and more with sort of the ability of people to be able to get these in compounded forms and whatnot. It's just becoming so readily available for people that I'm seeing people that are even just in the fitness community using it as a crutch for appetite. I haven't gone down that route. I'm a guinea pig. I mean, I'm willing to try all kinds of things, but I don't need to lose body fat. I don't need to, my insulin's under control. My fasting insulin's 3. I mean, it's low, right? So, but what would happen if someone that had stable levels, someone like myself, someone in good health that's also very lean, would it actually be detrimental?
It could be. We spent a decent amount of time discussing potential adverse effects. I do like to give a balanced approach. I guess that would be compared to what the alternative to that would be.
Yeah.
So for an individual that it would not be indicated in or that doesn't usually need it, there are often better things to help control appetite. I think it is a misnomer that GLP-1s have been called appetite suppressants, because really they're also insulin sensitizers, incretins. They have hormonal effects as well. They have absorptive effects as well. So they're definitely not just appetite suppressants.
Yeah, I think it's a really important note, because that's where people are starting to think that it is, and they're going that route and not looking at the big picture. And someone that's a metabolically healthy individual probably isn't going to, juice might not be worth the squeeze is what you're probably saying.
Yeah, very likely.
Well, as always, keep it locked here on my channel. And Dr. Gillett, thanks, my man. And where can everyone find you?
My main hub is Instagram, Kyle Gillett MD, Gillett Health on all other platforms.
Right on.